thank you for letting me spend some time talking to you about the hospital and the hospital levy and what's going on here in Mineral County in healthcare. The first thing I want to do is say I'm not a preacher, even though this is in front, and I have never taught school. This probably is an original one from the old schoolhouse, isn't it?
Probably, I don't know. Pretty
Well,
old.
as far as we're concerned, it was here when we got here, so it's original.
Okay, there you go. That works. For
Probably
me.
older than you are.
Yeah, it probably is. So.
Hell, it might be older than you now.
So again, thank you for letting me come and spend some time with you. The first thing I want to do is apologize. Apologize that I have to be here. I wish I didn't have to be, but I was brought into to Superior, into Mineral County, with the main goal of making sure that this hospital survives. So that's why I'm here tonight, to just talk to you about the hospital and what we're doing to try and make it survive. If I could go back and remake some decisions that have been made in the past, I would go back and I would remake some of those decisions, but I don't have that opportunity. I was listening to a speaker the other day who said that blaming somebody else has never solved a problem in the history of the world. So I am here to just talk about playing the cards that we are dealt, and going forward from here and trying to make sure that this hospital is still here in Mineral County, so that healthcare can continue to be provided in our county. One of the things that is out there that I want to make sure that everybody knows is not the case. This is not an ongoing levy. This levy proposal is for 2 years, and only for 2 years. The amount of it is $498,000 for each of the next 2 years, and I will tell you how we came up with that amount. And that converts for a $100,000 house. That converts to $5.34 a month, or 17 cents a day. So $64.09 a year on a $100,000 house. For a $200,000 house, it's $10.68 a month, or 34 cents a day. And somebody put it to me the other day, that 34 cents a day is less than a third of a candy bar. If you're going out to buy a candy bar. So what would happen if the hospital were not here? That is a very real possibility that this hospital will not be here. Like I've said, we've made some mistakes, and I can't correct those. And the mistakes have been bad enough that we've dug ourselves a very, very deep hole. And we can, once that hole is filled, we can continue to make this hospital work. But the problem is we've dug ourselves such a deep hole that refilling that hole is not something we can do with the patient volumes that we have at the hospital. So losing the hospital would mean increasing the travel time of our EMS crew to a hospital by an average of an hour to get there. So what can happen in an hour? If you are a stroke victim, it is extremely important that you receive the clot-busting drugs in a very rapid fashion. Another hour means brain loss. And there's an old saying that time is brain. And if you are not given those clot-busting drugs, it will cause brain loss, which causes severe disability in a lot of people. Cardiac patients, it's the same issue. Time is heart muscle loss. So we need to make sure that people get to that stabilization of care as quickly as they possibly can. we have lots of trauma victims, and you were telling me that you and your wife have seen 600 heavy-duty trauma victims in the last several years along this freeway. I received a card from a young man just not long after I got here, and all it said on the card was, "Thank you for saving my life." We do that every day. Saving lives in this facility means that initial stabilizing treatment to get people to the care that they eventually need. One of the other things that it really does is, all of you probably know that throughout Montana there's a severe shortage of emergency medical system staff, EMS staff. It's not just a Mineral County issue, it's a statewide issue. If it were to take an EMS person an additional 2-hour round trip to get to the next nearest facility, it's going to be a lot harder to retain those EMS folks to do those kinds of jobs. And right now we have a very difficult time recruiting young people into the EMS roles. If you've ever noticed the people who are out there on the ambulance, a lot of them have hair the color of my hair, and very, very few younger people are stepping into those roles in emergency medical services. If we lose the hospital, it's going to be even harder to bring those people into EMS. In addition, the loss of the hospital means loss of emergency room in the hospital, loss of ancillary services like the lab, the x-ray, the MRI, the CT scanner, ultrasound, all of those kinds of services. If the hospital goes away, those are another hour away for people in this community. And with some of the things that we see in this community, those services are very important to get as quickly as possible. CT scan and stroke. Dr. Pafford can tell us, those kinds of issues. So the hospital, when it comes to patient care, the hospital is very badly needed in this county. I spoke with our pathologist at the hospital the other day. She comes in from Missoula and is a supervisor of our laboratory in the hospital. And she was saying that the people in Missoula are very concerned about the loss of this hospital, because it means the people who are coming into the facilities in Missoula are going to be in far worse shape once they get to Missoula if this hospital is not here. So going past the patient care issues, which are obviously always the number one issue, on to some of the financial issues. Last year, for the year ended June 30th of 2014, the hospital paid out $3.9 million worth of salaries and benefits to people in Mineral County. If you pull that $3.9 million out of Mineral County in the form of salaries and benefits, there's a lot of businesses in this county that are going to have a lot of trouble surviving. People in the county count on each other to buy locally and to spend their money locally. And if you pull those kinds of wages out of the county, that money isn't going to be there to support the local businesses. If the hospital closes, Mineral County residents would need to leave the county in order to find work. All of you know that Mineral County is one of the highest unemployment counties in the state of Montana. There are not jobs for the 90 people who work at the hospital in Mineral County. They would have to leave Mineral County in order to find work. That has a negative impact on our schools as well as on the businesses. Right now there are 44 kids in Mineral County schools that are children of the people who work at the hospital. So it not only has an impact on the businesses, it has an impact on the schools, which then again impacts the local businesses. Retirees tend to not move into places where there is not a hospital. When you're talking to people who want to move into communities, there's some main things that they want to know about, and I think that you were talking about some individuals who moved into the community who wanted to know, is there good fishing? And that's one of the reasons I'm here, by the way. Is there an airport? These people wanted to know if there was an airport close by, and is there a hospital? Because if there isn't a hospital and you're retired, that health care is a long ways away. So what will happen if those people have to move out of the county and people aren't moving into the county is that property values will go down, and they will go down heavily. If there's nobody to buy these houses, once people move out of the county, they have no way to go but down. And I don't think that that's just on the lower income property as well. Again, if people aren't moving in, people with large amounts of property at high values, they're not going to be seeing people wanting to move in to buy those assets from them. So we're going to see some decreases in property value. One of the things that people I don't think are really aware of is that if the hospital were to close, we have what is called a hospital district, Mineral County Hospital District. So we have a hospital district and a nonprofit corporation, and jointly these two entities operate the hospital. All of the assets of the hospital and all of the debt of the hospital are owned by the hospital district. Okay, that is a subdivision of the county. And then the nonprofit corporation operates the hospital. Okay, so if the hospital were to close and that nonprofit corporation weren't running the hospital anymore, those debts do not go away. The amount that is owed is a debt of the county. So those debts would continue to have to be paid off by the closing the curtains.
I'm just getting, it won't work, it's too high. Don't worry about it. It'll move in a few minutes, I'll be fine.
There's an approval chair on stage.
Yeah, that might work.
Sorry.
One more.
Got
One more will do it?
So the hospital district would continue to exist, and the county taxpayers would be on the hook for all of the debt of the hospital, but there wouldn't be a hospital here to help towards paying off those debts. So that I see as a major issue of keeping the hospital in existence. Okay, well, so why do we need the tax money coming in? There's a couple of things. We owe a lot of money to various people, like I just said. One of the big debts that we owe is for our electronic medical record system. And our electronic medical record system was purchased at the cost of $750,000. $750,000. Electronic medical records were made necessary and required by the 2009 stimulus bill that came out of Washington, D.C. So all facilities are required now to have those electronic medical records, or they will cut your payments, cut the amount of money that you get paid. So while we needed that electronic medical record, there was a much better way to have done that. But I can't go back and remake that decision. So right now, we still owe about $600,000 on that electronic medical record system. It is costing us, between the lease that we have on that system and the maintenance contracts we owe, it costs us about $25,000 a month to keep that electronic medical record system in existence.
That's in addition to the 600.
No, that's That's the 600, we pay $15,000 a month to go towards that 600,000. Plus we have a maintenance contract that's another 10,000
Okay.
on top of that. So the total of those payments is $25,000 a month, but we owe about 600,000 still on the hardware and software side of it. When we purchased that equipment, it was purchased without much of a history. There's something that people call vaporware. It really wasn't software. It was more kind of pie in the sky when it was purchased. But it came out as a software package, and we have been working for a year now with that software package. We had the 1-year anniversary birthday of NextGen on March 18th. But in that time, a lot of bills didn't get out the door because we couldn't get information from the clinical side of NextGen into the billing side. So it took us a very long time to try and make this system work for us. We've spent a year on it. We are now to the point we're doing much better with the NextGen system. But what happens when you don't bill insurance companies or even individuals for a long period of time, they become much less likely to pay those bills. A lot of insurance companies that we deal with say you have to send the bill, or we have to receive the bill within 90 days of service. And if it's not within 90 days of service, then we're not going to pay it. Other insurance companies have different time frames, but since we couldn't get bills out the door because the electronic record system wouldn't work for us, we lost a lot of money in reimbursement. We went to a local bank and we asked that local bank to extend a line of credit to us so that we could get through this period. It took much longer to get through that period than it should have. So right now we have a line of credit of $560,000 with a local bank. And we don't have any way of paying off that $560,000 with the local bank. So in addition to that, we have another about $1.2 million worth of other debts for other things, including things like the CT scanner, and we put together some plans to build a new hospital, and without any funding to actually build the hospital, we paid a bunch of money for that. So like I said, we've made some mistakes, but what we want to do is we want to pay off the NextGen system, and we want to pay off that credit line. And if we get those two big chunks of debt out of our way, we can make this hospital work, and we can make this hospital survive. Okay. One of the things that we put right into the ballot initiative is it says when you get your ballot, it's going to say this. It says, shall the Mineral County Hospital District be authorized to make a levy of approximately 49 mills to generate an additional $498,000 for each of the next 2 years to pay past accumulated debt of the Mineral County Hospital District. This money is not to pay my salary. This money is not to pay anybody. It is to pay what we have accrued in the past as debts of the hospital. So if we are given the opportunity to have this levy passed, the board of the hospital district and nonprofit corporation will establish an account where every dime of this money will go into, and the only thing it will be used for is to pay past accumulated debt of the hospital. So we're making that pledge, and it says it right in the ballot language. So again, I realize we've made a lot of mistakes, and I'm making a vow to you. I will do everything I can not to repeat those mistakes. I've worked in healthcare for 34 years now. I'm an old CPA. I'm a pretty conservative guy, and we're going to do the things that we need to do in order to keep the hospital surviving. So at this point, I'm just going to open it up and let everybody have the opportunity to ask any questions that you would like. Yes, sir.
The next gen deal, where they play paperwork with you. Do you have in writing what they, my question is, can you sue the guys for failure to provide what they said, especially since there's still some money owed on the deal, and recover some of that, or renegotiate your note with them, or?
Yeah, we took this to our attorneys. This was prior to my arrival. It was taken to the attorneys. They looked at the deal, and the way that this was structured is kind of a unique situation. What they did is they said, we are going to contract with a leasing company. This leasing company is going to buy the next-gen system. The next-gen system is going to be provided to us, and we owe the leasing company.
I understand that, but the salesman who sold you the package deal was the one who was telling you this equipment will work, and was the one who offered the leasing company.
And our attorneys say we don't have a leg to stand on the way the agreement was written.
Interesting. You got a second attorney?
I think we've had more than one look at it, so.
Okay.
Yeah, the other piece of that picture is that it's not the kind of thing an attorney will take on a contingency fee basis. It would require us to put a bunch of cash out, not being sure we'd get a recovery. There actually is another hospital who purchased NextGen in a different way. They purchased direct, and they are suing NextGen. But
The other key
us,
to that is they never installed it. They just gave them the money and didn't get it installed, and so now they're just suing to get their money back that they gave to NextGen. But they had money to give up front.
Yeah, I was wondering how many other hospitals are in the same situation, and you might find a real tall dog that was interested in it, and might take a group. I'm just curious.
yeah, no, and we don't think many hospitals bought NextGen, quite honestly.
Okay.
It's a system that works relatively well in a clinic setting.
It
does
does.
not work well in a hospital setting.
I installed it in the clinic in Chester, and it's still working and working very well in the clinic in Chester.
Yeah.
But they decided that they wanted to get into the hospital side, and so they went and bought a system and then said, we're going to install this system on the hospital side. So NextGen in clinics works pretty well. It's and the issue was more an issue of nothing tied together within the system, and then when you add that to the lack of training of our mainly our nursing staff and our providers, very little training to get things into the system, to get charges into the system, to get them to the financial side, to get them out the door.
Yeah.
And so that, we are now making it work, but it's taken a year. It's taken a year.
Who got us into this mess? As a taxpayer, if you expect me to bail you out,
Yeah.
I want to know who's responsible for this. Somebody's mother.
Yeah. I wasn't here at the time. I know that there are people that we would like to blame, but like I said, at this point I can't blame people because it's not going to solve the problem. I just have to go from here, go forward, and
Well, I have to presume that either the CEO, I guess, I don't know, you haven't really said where this thing got sourced from, but between the CEO, hospital administration, and the board of trustees, somebody should have been overseeing this. And I would hope that those people who had responsibility for $1 million+ here were bonded.
yeah.
No.
Yeah, well, they were bonded, but bonded doesn't mean that you pay for errors in judgment.
And
And
bonded
that's
is if
what
you stole
these
stuff.
were, yes.
Yeah,
These
bonded
were-
covers if you steal.
Yes, these were errors in judgment.
There was no E&O coverage?
Oh, certainly there was. But they're errors in judgment, and insurance companies don't pay for errors in judgment. They pay for, if somebody stole $50,000 from the hospital, they'll cover it.
So the taxpayers get to pay for the errors and judgments. That's what it boils down to.
Unfortunately, that's the situation we're in at this point.
Yeah.
And it's not a happy one, and we weren't happy
Yeah.
to have
Like
to
I
bring
s-
it to the
Yeah,
public.
like I said, if I could not be here, I would
Believe me,
prefer
I
not to
understand
be.
that. I understand that. But as a taxpayer, I'm getting tired of bailing out government,
Yeah,
and that's what we're doing again.
yeah, I understand.
What commitment could the hospital district make to share in raising up these funds? Do you have assets, for instance, that could be sold? And then to raise money up to maybe a dollar for dollar, what you're asking the public versus to cover your own. You know, you have to have some skin in the game.
Yeah, there aren't any assets to be sold.
There's a building sitting in St. Regis.
That's-
That was interesting, the way that was done as well. That building is sitting on land that does not belong to the hospital. Yeah.
And it was built, I've heard lots and lots of different rumors, and most of what I've heard is not just unsubstantiated, but outright false. How that clinic was built is there was some grant dollars that came from the Human Resource Council. There was a $144,000 loan from Blackfoot Communications, and $75,000 worth of hospital money that was put into the construction of that building. What came from outside of the hospital was the land, and the land was only provided until there was no longer clinic services being performed there. So now the land is not, the land was never owned by the hospital. So, yeah. Like I said, we've made some mistakes.
So who owns the nursing home and the clinic?
The nursing home, hospital, and clinic are all owned by the hospital district, the county. Every asset in that facility is owned by the county.
So conceptually, could the county sell the nursing home to help raise money to pay these
Yeah,
guys?
there is no longer a nursing home. It's a 25-bed critical access hospital. So there isn't a nursing home. There's an assisted living
So
facility.
assisting this.
Okay. And the assisted living facility, I have some plans on something that we can do with the assisted living facility to help us a little bit financially on that. Again, assisted living facilities cost critical access hospitals money when you build them. Assisted living facilities should be constructed outside of critical access hospitals every single time, but all of the critical access hospitals, I mean, many of them made that same mistake. Because what happens is you build an assisted living facility and you make it part of the hospital. The way that Medicare does this is you submit what's called a cost report every year. And the services that Medicare provides, when you're a critical access hospital, they pay you at their definition of cost, less a little bit, under sequestration and some of those kinds of things. So they pay you what their definition of cost is. If you put an assisted living facility, which Medicare doesn't participate in, under the hospital, then Medicare says, aha, a bunch of this overhead now relates to that assisted living facility. So they take money out of administration and these other areas and put it down into the assisted living facility, so there's less money left in the pool that Medicare will participate in. So just having that assisted living facility on the hospital's books costs us about $30,000 a year. So we're looking to reorganize how we have that assisted living facility, move it out from underneath the hospital, try and get it separated from the hospital so that we don't have all that overhead leaving the hospital. So there are some things we can do with that. I don't know that anybody is willing to purchase an 11-bed assisted living facility. They are not exactly profitable. So small assisted living facilities, we tried to sell I think it was 18-bed one in, because we had the same situation in Chester. We tried to sell it, nobody wanted it. So selling that small of an assisted living facility is not likely to happen.
What about outside services that you contract for? You see the trucks pull up and for this service and that service. Is that all necessary in these next 2 years?
Most of it is, yeah. I'm not sure which services you're talking about, but for example, like Cisco and they provide our.
No, I thought they had CT scans.
We have an MRI.
MRI.
Yeah.
They
the
drive up in the truck.
Right. The MRI is at our facility 1 day per week, only on Mondays. We are a partial owner of that MRI system. If we were to back out of our, or try and sell our ownership of it, the cost, what they would charge us for the service would go up, because as an owner, we get a break on the MRI services. We are one of, I think there's 6 owners in the MRI that was set up. Oh my goodness, it's probably been 10 years ago that the MRI group was established. We provide enough MRIs to pay for the MRI to be there. It's not like the MRI is costing us any money to have on the campus. That 1 day a week, yes, sir.
Ron, just listening to you, listening to the folks here, we could all live under the Old Testament admonition that we are responsible for the sins of our fathers, either collectively or individually. That's a rough road to hoe. I don't want to do that. I don't want to live under that admonition. That's not reasonable, nor that's not what reasonable people do. We move on. What I'd like to have you do, since I have a vested interest personally, I'm also on the foundation. Why did you take the job, first of all?
He's probably asking that question.
I knew you took it because you could see the light at the end of the tunnel. And also, secondly, would you please enumerate, and I know there are many, the positive things you see within this medical community?
Sure. I grew up in Ronan, not too far from here. And as a kid growing up on the Flathead Reservation, I was not able to hunt on the local reservation. So I came over and spent my childhood hunting up Dry Creek. And when the job came open in Superior, I looked at it as, wow, I could go home. My parents still live in Ronan. My dad's 80th birthday will be on April 25th, and we're having a big bash for him. At the age of 80, and my mom is 79, I want to be back on this side of the mountains. I spent 25 years in Washington after graduating from the University of Montana. And then I'm a slow learner. It took me 25 years to figure out I wanted to be in Montana. So I took a job at a little critical access hospital in Chester. I had spent the previous 25 years helping little hospitals. That's what I did. I was a CPA that did nothing but healthcare work. And so I spent that 25 years working with little hospitals. I want to see this hospital survive. If there's anything I can do to make it survive, to help make it survive, that's what I'm going to do. So that's why I'm here in Mineral County. We've done a lot of good things since I arrived. We've got a very good medical staff. We have some incredible people who work at the facility and do their jobs extremely well. I think we had some bad management of people who do their jobs extremely well. We've instituted some things at the facility because we want to change the perception of the hospital out in the community. And I recognize that the perception out there needs to be changed because perception is quality. Regardless of how good the quality you provide, if you perceive that it's not good, it's not. So we've done a couple of things. The first thing we did, and Monty has been training our staff on something called AIDIT. It's a little acronym that we use to try and remind people of how they're supposed to treat the customers that come into our facility. It's 5 letters, AIDET. And the A stands for acknowledge. When somebody walks into the facility, you acknowledge them. And it's the old 10-5 rule. If they get within 10 feet, you acknowledge them. If they get within 5 feet, you say hello. And you try. We're trying to impress on people how important that is. I is for introduce. You introduce yourself. If you know the person's name, you use their name when you're introducing yourself. D is for duration. If there's going to be some kind of a wait, you tell them how long it's going to be. You keep in contact with them. You don't let them sit in a waiting room for a half an hour wondering what's going on. E is for explanation. We've got somebody sitting here, Chris, who is an expert at explanation. If somebody comes to Chris for a mammogram or a CT, she's going to tell you exactly what's going to happen, how long it's going to take, why she is doing what she's doing. And then the last piece is thank you. And every single time we need to be thanking people for coming to our facility because we depend on them as part of the community. So that's one of the things we're doing. The other thing we're doing is we're trying to live by a book called the Florence Prescription. And within the Florence Prescription, there's 7 daily promises that we make to each other. We get together in the mornings in the lobby of the hospital, and there can be 35 people standing in the lobby of the hospital. It takes 15 seconds to say these promises to each other, but we make promises to each other. And the reason we do that is so that we can hold each other accountable for those promises. For example, Monday's promise is responsibility. And it says, I will take complete responsibility for my health, my happiness, my success, and my life, and will not blame others for my problems or predicaments. That's one of the reasons why I'm having so much of a problem stepping back and saying it's somebody else's fault, because I need to be taking responsibility for where I am. I took this job, I need to be responsible for it. We have those promises that we make every single day to each other, and if I don't live up to that promise, I expect somebody to come up to me and tell me, you're not living up to responsibility today. You're not living up to accountability today. You're not living up to faith today. So we are impressing on our people that those are the kinds of things that we have to do in this community in order to improve the perception of the hospital out in the community. I hope I answered your question, Roger. Any other questions?
Getting back to the fixes,
Mm-hmm.
what about bankruptcy? I mean, cities declare bankruptcy, people declare bankruptcy. What about hospital reorganizing?
Bankruptcy reorganization only delays the payment of the debt. It doesn't generally do away with it, especially if you're going to continue to operate the organization. It would be very difficult to do a bankruptcy of the county hospital district because the county is on the hook for all of the debts. So bankruptcy, while I guess it's possible to to do it. I have not heard of a bankruptcy happening in the state of Montana of a county.
Because it's a county debt, it would have to be essentially the whole county that went bankrupt.
Speaking of which, do we have a county rep here tonight?
I don't know. I don't know if we've got anybody here.
In terms of county commissioners, no, I'm the elected chair of the hospital board. So in a sense, I'm part of the hospital district.
Right.
So in that sense, I'm a county rep.
Right. The county hospital district, the way it's organized, there are 5 elected members of that district board. And we had 3 open positions for the last district board, and we only had 2 people apply for those open positions. So we're always looking for people who are willing to step in and try and make change within that district board. And then once we have the district board established with 5 members on the district side, there are 4 corporate board members for the nonprofit corporation. So those 9 people make up the board of the hospital.
And you're the only one here?
That's correct. I will tell you that we've worked hard too, and we're continuing to work to make sure we have a good, strong board as well. I recruited specifically one of the people that's running in May, an individual who has years and years of experience as a town chief financial officer, so very focused on numbers and finances, and also a very strong-willed woman who will ask questions and will not accept anything less than a full answer. Can also tell you, working with Ron, that's not a problem. We get full, complete set of financial information every time, which was not the case when I came on the board.
How long have you been on board?
I came on the board, I was elected May 2013, so I've been on a year and a half. The problems were there when I came on. What I found when I came on, honestly, I sat down in my first board meeting and there really wasn't any financial information in the packet. I got this nice little new board members book though, and I took it home and read it. And I read the whole thing, and the last section was an article on the specific financial indicators that board members should be watching to determine the health of critical access hospitals. And I said, there's where I need to be focusing. Went to the next meeting, and none of that information was in the package. And I started pushing. And I can tell you, we now get all of that information on a regular basis. It goes up on a smart board with charts. I've already seen it in the package. I get it a week ahead so I can study it and ask questions when I get there. And you have a board now who is looking at that kind of thing. We're paying attention to it, and I'm looking wherever I can find them for more people for that board who are willing to do the same kind of thing. We want a strong board. I had an email exchange just this last week from somebody who was apparently on the board previously, complained to me that they hadn't been able to get financial information. It got pushed out for asking, they said, and they were very frustrated. And I said, well, please, come to our next board meeting, see the kind of information we're getting today, and while you're at it, would you consider coming back? And if there's anybody in this room that is interested and really willing to put the time in, one of the other things I've felt, we don't have anybody right now from the west end of the county, and I think it would be good if we did get somebody. We don't at this particular time have any openings, but I'm sure openings will arise, and I'd like to have somebody from this part of the county to have their voices represented. And I want people that will make themselves heard and make management toe the line. Not that I think there is a problem at the moment. Quite honestly, I think when Ron's application came through the door, we were kind of pinching ourselves at how lucky we were to get somebody with his level of expertise and experience. So.
Well, one of the things that, like I said, I'm an old CPA. And one of the things I live by is what you can measure, you can manage. What you can't measure, you can't manage. And the board from this organization was getting 0 information. So how in the world could they be expected to manage an organization when they were getting zero information? We now have, there's a group out of North Carolina, University of North Carolina, who every year they pull together data from every critical access hospital in the country. All of the cost reports that are filed with the federal government flow into one database. And they pull that information out of the cost reports, and they prepare information that tells you what the norms for all of the critical access hospitals in the country are, the norms for hospitals in Montana, and the norms for hospitals, critical access hospitals your size. So I can take that information, I can lay our information next to it and say, here's what we're doing wrong, here's what we're doing right. This is where we should be, this is where we are. And at least the board has the information that this is where we're trying to get. But prior to that, they had none of that information. They didn't know what they were trying to achieve, and when it came to financial information.
There was that same North Carolina group actually that was responsible for the article I was talking about that I was looking at, well, okay, so where is the information? And we started pushing for it, and we started getting it, and that whole process also was part of leading into the change in management.
I'm to the point where I'm hoping the board doesn't get sick of all of the information they're going to get, because this last month I added a whole bunch more stuff to the previous month's report. I'm kind of having to build over time all of this information, pulling up information from, I give them 4 years worth of history. So, for example, what's happening in the hospital right now is our emergency room visits are going up. Okay, but our admissions from the emergency room are going down. And our transfers from the emergency room are going down. What's that telling me? That's telling me that I'm getting more and more less acutely ill people that are coming to the emergency room for services. So I need to be working with the clinic to say, okay, how can we get some of these people to not come to the emergency room and instead use the clinic services for those kinds of things? Because there's no way that all of those sniffles are happening at 6 o'clock at night. They happened at sometime during the day, but it wasn't 6 o'clock at night. So they're coming to the emergency room with very, very small problems. And it costs the community, and it costs the insurance companies, and it costs everybody else more money when they come to the emergency room rather than going to the clinic. So, yes, ma'am.
Is there a possibility of having an urgent care facility there that would be in addition to clinic hours, and then maybe scaling back on the trauma level that we are maintaining in the ER, as far as the amount of personnel that means you maintain in the ER?
With the way that we are organized currently, we're not going to be providing any primary care services out of the hospital. Primary care is the responsibility of the clinic. Okay. Urgent care centers, if we had another 12, 14,000 people in the county, an urgent care center might pay for itself. But it's right now, it's costing us about $600,000 a year just to pay the providers to keep our emergency room open. And when you take $600,000 and divide it by 12 or 1,300 emergency room visits a year, those numbers don't work very well. So we're trying to figure out ways to work better with the clinic to try and keep some of those numbers at a lower level. Some of the dollars at a lower level.
Yeah. No, I was thinking that, John, you know, a few years back, we fought to be a certain trauma level in the ER, that we were not prior to that. Is that costing us more than we can afford?
The only thing that the trauma certification costs you is the time for people to do things that they should be doing anyway. Okay, so trauma certification, the level 5 trauma certification that we had, what it requires is that you take those trauma cases and you review them every month. So it takes time to do that. You have to have certain policies in place, you have to be doing certain procedures. There are certain things medically that you have to have available, but it's not costing us very much more to have a trauma certification. What it does do is it keeps us on our toes when it comes to treating people with trauma. That's why we lost our trauma certification. That was one of the things that happened a year or two ago. We lost our trauma
We're
certification.
working on getting it back.
We are putting it back together, but that's not what costs us the money. What costs us the money is just having those medical providers there 24 hours a day, 7 days a week, in case somebody happens to come into the facility.
Ron?
Yes.
I mean, just for clarification, we lost that certification not because of the competency or anything.
Oh, no.
It was because of the administrative requirements,
Right.
the review process that you have to show in order to keep your designation as a level 5 trust.
We were not tracking what we had to be tracking in order to prove that we were qualifying for the trauma status.
And correct me if I'm wrong, the benefit of having that designation was that when we did call a trauma team, we were slightly better also
Sure.
for having gone through the extra trouble to
Right.
call together a group of people to do that job. We're doing it before anyway. But, you know,
When you call a trauma alert, sometimes you have to bring in extra staff, sometimes you have to do those, it costs you more money when you've got serious trauma, 2 or 3 people in the emergency room with some kind of serious trauma. You can bill that differently than you would just a normal emergency room visit. So when you do a trauma alert.
So is there any place that can be scaled down, cut back, whatever, to save money, that could maybe pay off debt, that could,
Well, let me tell you what we've done. 2 years ago, we had, when you're talking full-time equivalent employees, that is, right now we have 90 total employees. And when you take all of those employees, some are part-time, some are full-time, so 2 part-time people equals 1 full-time person. So once you collapse those all down into full-time equivalents, right now we're about 71. And 2 years ago, we were at 95. So we have done some of those things. We have reduced the amount of staff that we've got in the facility. When I came in, there were a couple of areas that it was clear that we were overstaffed, and that was just, it was easy to find some of those things because of what I've done in the past and where I came from. I knew that we shouldn't have that level of staff here. Now, are there more of those kinds of things we can do? There probably are. But we now are actually getting information. So what I can measure, I can manage, and now that I can measure some of that stuff, I can do a lot better job of finding those things.
Is there not a way to triage the ER with a limited, maybe a clerk, that if this is a sore throat or a child with diarrhea, there is a schedule for the doctors in the clinic for the following days and setting up appointments? In other words, can we basically draw the line? And I worked as a volunteer for 25 years in hospitals in Texas. This has been going on for 50 years, as far as I know. So I don't understand why our brains haven't figured out that we need triage at the door, not on a gurney, and start charging a nurse for her time.
Yeah, there's a federal law called the Emergency Medical Treatment and Active Labor Act, EMTALA, that was passed. How long ago was it passed, Jenny?
87.
87. Okay.
Because of a gunshot wound in Chicago.
Right. There was somebody who was laying out in a parking lot, and the hospital didn't do anything about it. So because of that, the Emergency Medical Treatment and Active Labor Act was passed. EMTALA says that every person who walks into your emergency room has to have a medical screening examination completed by a competent professional.
I wish Intella would pay the bill for that. Whoever they are.
I understand,
And
and
I think it's.
that every time a federal law is passed, it costs us money. There's no
Yes.
doubt about it. And very rarely is there compensation that comes along with those federal mandates. But EMTALA is one of those issues that we call the guy who's the PA or the physician and say, come on in, we got somebody in our emergency room. So that's an issue we have to deal with. There's a difference between triage and the medical screening exam. Triage is when somebody comes, when you've got 3 patients in, the nurse goes and says, you need to go first. You need to go second, you need to go third. That's triage. But a medical screening examination, it has some very strict, according to our medical staff bylaws, has some very strict requirements that we have to follow in order to meet the requirements of EMTALA.
So what happens if you don't?
Well, if you don't, they take away your
2:30 in the morning.
They take away your meal ticket. Actually, they can fine you up to, as a critical access hospital, they can fine you up to $25,000 per incident. It's $50,000 in the bigger hospitals, but for us, it's $25,000 plus. It could be $25,000 to us, $25,000 to Dr. Pafford, $25,000 to Brian Rick. They can make these things build up if you're not meeting that Emergency Medical Treatment Active Labor Act requirement. Yes,
Times
sir.
3.
Yeah, it
Treble
could be treble damages. Yeah,
In
if they,
2001, this started in 87, and it grew from there. In 2001, they decided that if anyone comes onto the hospital's property seeking emergency medical treatment, they don't even have to make it inside the door wanting to see a provider. If they are anywhere so much as in the parking lot, if they are in an ambulance that's owned by the hospital. So again,
yeah.
the federal law says we have to see every sniffle, and Dr. Pafford gets to decide whether or not that sniffle is.
And the night nurse is not allowed to be the one to decide. It requires.
It requires the doctor.
Yep, to decide whether or not it's an emergency medical.
Wow.
And we haven't even got to discussing HIPAA yet. I remember.
By the way, I like
to
running noses.
redesign their offices. They actually had to redesign their offices because of HIPAA.
Yeah.
And
Yeah.
a lot of times, I think part of the frustration is that, and I think we have to guard against this, is that we see so many things happening around us that we kind of ask why. We're sort of like the old movie, which was made in '69, and it is a Western, so I think it's appropriate. And it's called Butch Cassidy and the Sundance Kid. And Robert Redford and Paul Newman, if you remember, they're always stopping because they're chased by the posse. And you see the posse at night too, and you see the lights way off in the distance. And Paul Newman keeps talking to Robert Redford. He says, Butch, who are these guys?
Who are these guys? Yeah.
Sundance, who are these guys? So we get into this mode. I think it's because we don't see the control that we have. And we're dead set. We're anxious because we don't have the control. And then when we hear these things about, well, we're going to be fined $25,000 if Dr. Bradford does something wrong, or the nurse does something wrong. And it's an anxiety level. And we wonder who these people are. But what we have to do, and I'm preaching a little bit because this is what I like to do, but I think it makes sense. I'm confident that we need to focus on taking charge of our lives. What can we take charge of? And I'll be damned, I'm not going to let this community and myself become a second-class citizen. I was born in America. I was born in the United States. I am not accepting second-class citizenship. For 15 cents, for 30 cents a day, I'm going to become a second-class citizen if I don't vote for this? It's stupid. It doesn't make sense. I want to be able to see Roger Pafford or a nurse. The nurse is better looking than Roger Pafford. I want to see these people. I want to see you. I want to see, I want to commiserate with this man. I want to talk with John. It's my community. It's my community. The feedback I get is very positive. But I'll be damned if I'm going to, if I can use that language, that I'm not going to support something for 15 cents or 30 cents a day. With me, it's going to be a little bit more. It's probably going to be more like 50 or 60 cents. But I can do it. I mean, it's not even a Guinness. It's not even a Guinness. It's not even 3 or 4 Guinnesses a week, which I haven't had one in a month. I mean, but does that resonate with us? And then we can take control of these lives that we have here. I can go and see Ron. I can show up at a meeting. I can see John in a meeting. I can go to this meeting.
Absolutely you
But
can.
how many of us go to the meetings?
They are open public meetings because of the hospital
That's
district
right.
component.
These are public meetings. I can voice my opinion.
And I would like to have people come and see what goes on. I mean, once you understand more about how complicated it really is to run a healthcare organization, I think you'll get a better understanding, and it helps you support the organization. So, yes, sir.
Is your staff worried about losing their jobs?
Yeah, absolutely they are.
Have they offered to contribute by taking a lesser salary to show goodwill to the community to try and sell the idea of the increased taxes?
We have the AFSCME, the union that we have, came to us and said, is there a way that you can not do our bonus this year? The problem that we've got is, and anytime, like I said, anytime the government gets involved, things get more complicated. The state government decided that they wanted to improve the wages or the compensation for long-term care workers. So they established something called the direct care wage add-on. And every year we can apply for the direct care wage add-on, and the state sends us some money, and then we distribute it to our employees. That's how we're paying for a good portion of those employee bonuses. So we have, while the union offered to do that, it was either give them the money or give it back to the state. So obviously I'm going to give it to the people who work at our facility. We have some very, very low-paid people in our organization, and I don't want to harm them financially either. So, but we have a lot of good jobs at the hospital.
And you're locked into wage and hour law, then somebody cannot
True, plus we have a
do
union
some
contract.
additional work as a donation.
Correct. Yeah, we have a.
We killed the wrong people in Vietnam.
Do you want to run an organization like this on volunteer work?
Yeah,
Doesn't sound like a plan to me.
yeah.
What is the definition of, you used the term a couple times, and I probably
Okay.
like critical care facility?
Critical access hospital?
Critical access hospital.
A critical access hospital is a specific designation that was really born here in the state of Montana. Montana, when the federal government decided that they were going to pay every hospital in the country based on diagnosis-related groups. So regardless of what it cost you or how much care you provided to an individual, you were going to get a single payment amount for that. I think 400, the number is, the 6 in my head is 400 little hospitals died, went away. So Montana came up with, they got a grant and put together a program where they were doing a demonstration project called medical assistance facilities. And it was the smallest facilities in the state that they tried to get them paid based on a different way from the Medicare program. That program that was born here in Montana then became the Critical Access Hospital program. To be a critical access hospital, to get the designation right now, you cannot operate more than 25 beds. have to be located more than 35 miles from the next nearest hospital or critical access hospital. You have to provide certain levels of emergency room coverage. You have to have an emergency room. You have to live by the standard that there will be a provider there within 20 minutes of somebody showing up at the door. There's a lot of those kinds of rules. You have to have certain amounts of staff inside of the hospital to take care of if somebody in an emergency situation does come. So there's minimum staffing requirements. All of those kinds of things went into building this critical access hospital program. It was originally intended for places like Superior and like Chester, Montana, because it was built here in Montana. That's where it came from.
Is that like the bottom tier of
It-
hospital?
Well, now there are 1,800 of them in the country. So, and some of them, Whitefish has a critical access hospital. Hamilton has a critical access hospital. In my opinion, that's not what it was built for. It is places where the need in those communities is critical enough that the federal government decided that they would pay us differently. Okay. What happened though is Senator Grassley back in Iowa found out about this program and what we were trying to put together. And he got put into the legislation that critical access hospitals could also be designated as critical by the governors of the states. In addition to meeting that 35-mile goal, the governor could just designate something. That's where all of these critical access hospitals came from. Our facility met the original intent of critical access hospital, as did most facilities that are CAHs in Montana. But there are now critical access hospitals. There's one in Pasco, Washington. One of the Tri-Cities? That's a critical access hospital. So because of this governor designation, the governor's just said everybody is critical. And anybody who wanted to be a critical access hospital could be. So the program it snowballed. And we, a couple of years ago, tried to get the government, the feds, to say, okay, you did this CAH thing, let us take a step back and concentrate back on what this program was intended for. And we worked for 2 years on that program, and it really went nowhere, trying to convince people. We went back to Washington, D.C. I met with, I was at a White House meeting on this Frontier program. And one of the things I told people is, the people back here do not understand what rural is, what frontier is. You don't get it. People here in Washington, D.C. think Buffalo, New York is rural. And I think Buffalo, Wyoming is urban. And there's a lot of difference between these two programs, these two cities. So we tried to get them to take a step back. Hopefully, at some point down the road, they will take another look at this. I think they think they've got their hands full with the Affordable Care Act and some other things that are going on. They really haven't been paying attention to the frontier issues right now. So, yes, ma'am.
A couple of little things. This area in particular, at least as I see it in my mind, we have a lot of people that live up in the mountains that come down. Rolla can tell you that. She's been hospice longer than I've lived here. They come down every couple of weeks. They used to come down and go to the clinic, but my concern is that they may be Medicaid people who have no information. They're not going to get your newsletter, Ron. They're not going to be at a meeting like this, no matter how many bulletins we put up at the post office.
Sure.
And these are the people I believe our hospital is greatly serving.
Absolutely.
And without the hospital, these people will have to go great distances. Are we being careful to do enough to reach them in some manner? For instance, if they happen to be taking advantage of a program at the clinic, are they being told when they come to the clinic what's going on? I know you have a brochure. The other thing, little thing, please don't forget to mention about this being mail-in. That was a big surprise.
That's very, very true. That's a very
It's a
good
mail-in
point.
vote.
Yeah.
Looks like.
And any help that we can get with reaching people is greatly appreciated. We have to be a little bit careful with
What you're able to do.
nonprofit organizations getting involved in political
Like,
things.
one of the
but-
things we might do is take a stack of these to
Absolutely.
the DeBorgia post office.
Wonderful.
That is the place where people gather. That's also the place where eventually even the guys that don't like us too much, that want to be up there forever,
Yeah.
who are fine,
Right.
might come down.
Absolutely. That's why I brought these, is to get them to where they will get the most read.
Because we're not the greatest at passing levies out here, and
Oh, I
part of it
understand.
is, and you already know that, and, you
I
know.
understand.
Nobody knows better than Cemetery District, who tried for 5 cents, so, or whatever it was we tried for.
Yeah.
It's a concern.
But you are correct. This is not, there will be no polls open on May 5th. If you are a registered voter, you will be getting a ballot in the mail.
Excuse
And
me, there will be school board elections on May 5th, so there will be polls here, but we do
Oh,
not
okay.
have,
Why won't the initiative be hidden?
I don't know why.
That doesn't make sense.
yeah,
Because I happen to be a judge, I mean, so I
Okay.
know that we're
Okay.
having an election here. for
the,
school boards.
I was told by the county that this ballot would be 100% mail out.
Right.
So you have to return this ballot to the county courthouse in order for your vote to count. So the ballots will be mailed out either the 10th of April or the 13th of April. There's a window that they have for mailing the ballots out. But you can't vote on this any other way than through that mail-in ballot. So, and generally people vote on mail-in ballots within the first week or two of receiving them. While the actual election day is May 5th, we're trying to get out way in front of this and get out to talk to people. We've got meetings scheduled for here, Superior tomorrow night, Alberton on Wednesday night, St. Regis on Tuesday of next week. I go back to the Alberton Town Council on Wednesday of next week. Last week in 3 days, I had 8 meetings with various people. We are trying to get out to as many people as we possibly can to talk about this issue. And any help that you guys can provide us by getting out and talking to people about it, the more the better. So, yes, sir.
I was just going to bring a little attention to the handout that was made. I find the real value of that is, I've lived here 2 years, 4 months. Okay. This is the first time that some of that objective, concrete information has been put down for us to read. Wow, that was such a beautiful thing. It's like, oh my gosh, here's facts. I like facts. Facts are good. And to me, the nice part about that is if you can get that in the hands of people, say, well, just open the thing up and look at it. It's a first. It's a real first.
Thank you. Yes, sir.
You said you went from approximately 90 full-time equivalent to 70
95.
full-time equivalent.
Yeah.
What did that do to your employee costs, plus all benefits and that sort of thing?
Oh, boy.
The reason
You know,
I don't
I was not, all I'm doing is going back in time and trying to gather as much information as I can.
The reason for my question is that's the first time I have heard of you actually reducing staff, which is good, and that probably would be an item that I would put into my editorial submission to the Mineral Independent. I say the chairman, somebody that knows how to write, and list some of the efforts that you have already made that are concrete, that people can see and say, hey, these guys are really trying.
Another one of the
Because there is
things.
a different aura out there.
Oh, I'm sure, I'm sure. Another one of the things that we did here recently is we hired this young lady who's sitting right here. And in the first month, she cut our overtime in half. Simply by taking a look at the schedule and saying, I've got 2 monthly time payroll periods, if I schedule correctly, people are not getting paid overtime because they're going over these periods. So Jennifer she cut our overtime in half in the first month.
And I published that,
But that's a
Sure.
positive.
because that's an extremely positive thing.
Mhm.
And I think that that's information along with your brochure that you need to show that, okay, this is short-term accomplishment. We're not gonna away your taxes. We have a real attempt with somebody that knows what he's doing, and a chairman that's an SOB, because I knew him. And that maybe.
And he's not gonna let me get away with it.
Are your corporate board members elected?
The corporate board members it's a nonprofit corporation, so it's a self-perpetuating board, but the corporate board members are appointed by the elected people.
Oh, okay.
So, and I think we have an open position with two applications right
that we'll
now.
be considering this Thursday.
Both excellent.
Anybody that's interested, please though, put your name in the ring.
Absolutely. Absolutely.
We do want good people, and we want people that are gonna speak out, so.
Yeah.
Okay. My last question, and I'm done harassing.
Okay, that's okay. That's okay. That's why I'm
Cut
here.
to the chase, the bottom line, no shit, if this doesn't pass, is the hospital gonna close?
It is very likely that that's the case, because what will happen is we won't be able to pay that credit line. If the bank calls the credit line, there is no money to pay it. So what do we do? I mean,
if this doesn't pass, we're not going to give up. So I'm not gonna sit here and say it will close,
Okay.
but we don't see the
I guess that's what
path.
I'm looking for.
Yeah, we
What
don't,
else are you gonna try?
we don't
if
see
this
the-
doesn't work? 'Cause
I don't know what else to try offhand. We don't see the path forward without this. But if this doesn't pass, I'm sure not gonna just throw my hands up and give up. I'm gonna do everything I can to try and keep it alive, but I don't know what that path is right now.
let's put it this way. If the levy doesn't pass, I'm not buying a house here. Because I don't have the faith that we can make this work. Do I want it to work? Absolutely. I do not want to move again. You know, I want to spend the rest of my career in this community and in western Montana where I grew up. I kind of like going fishing every once in a while. So yes, sir.
Would there be any advantage to having the Providence group look at you? Where you really have deeper pockets?
We have talked with community, we've talked with Providence. They're willing to, they talk like they are willing to help us with getting some possible providers in. Nobody has been willing to help us with money.
How about?
Yeah, and they so far haven't actually come through with the provider side.
That's very true too. Yes.
Community trust that just got funded.
I went
It's in chaos. Chaos sometimes gets you something.
I went and talked to Steve Carlson when this was all coming together, and I said, so what are the possibilities? Is it possible that we could get some dollars out of this trust once it goes into he said, you might as well buy a lottery ticket.
No, that was Carlson.
That was Steve Carlson.
Okay, who were the docs on the board?
Um,
No, I'm just.
there is no board established as of yet,
I
as far
know,
as
as
I
I
know.
said, it's chaos.
Right.
But
Yeah. I actually thought about putting my name in and maybe seeing if I could get on that board. But as a member of the community, the greater community. The way I understand that it's going to work, at least this is what I hear, is that they're going to take all of those funds, set them up in trust, and then they will pay out of the trust earnings off of those dollars, which is not very much money.
which there ain't none.
Right.
Yeah.
Yeah.
Not safe.
So like I said, Steve said you might as well buy a lottery ticket if you're thinking about
Bad
getting
idea,
something.
Selling lottery tickets is better than buying.
That's very true,
Yeah.
yes.
There's There's a little issue with the odds there.
Yeah.
I have one last question.
Yes, sir.
Have you investigated the possibility of a sales tax, which would, small 1 or 2% and, for the 2-year period and pick up some tourist money?
Have not. And I don't know if, I suspect, well, there is one in St. Regis. There's some kind of a tourist tax.
The amount of money that's spent by tourists in this county for this
It's
county
significant.
is a lot of money.
Yeah.
And I'm looking for ways of taking a little of the burden off of the property owners.
Yeah, I
I mean, this
understand.
is, we talk about how much money it's gonna cost, but that's incremental to what you're already paying.
Yeah, I understand.
So if you can have people from Washington
Don't
based,
dance.
if you have people from Washington based, some of this would be nice.
Yeah. Yeah, that's a thought. I hadn't thought about attempting that. That's something that the county commissioners would have to get involved with.
Sounds like we need to be involved. They're ultimately responsible, whether or not. That's why
True.
I'm disappointed there's none of them here.
And we pick up the people that also, that would, that are not property owners,
Exactly.
and get them to contribute.
And I'm not sure how the resort tax works in St. Regis, if it's just off of the lodging, or how that resort tax is charged.
I think it's part of our personal property tax.
No, it's not property tax.
But how come
You can't tax like home products, things that people use in their home, like decorative items, furniture.
Likely food and.
Yeah.
you know, all that sort of
That- And you have to prove that your community gets a certain percentage of its income from tourism. So I'm not sure that any other community in the county does that.
Yeah, St. Regis gets a lot of through traffic
Yeah.
headed for Glacier and Whitefish that comes off the interstate.
I've been surprised how much money is spent just in gas stations
Yeah,
and lodging.
Oh, yeah.
Gift shops and that.
Gift shops, whatever.
yeah,
And just a little bit of that money, that would go a long way to help.
yeah. Very well. That's a good thought. Thank you.
And for 2 years, just say for 2 years.
It
Good
could
thought.
be, it could be sold as an idea, because you need it now. Our sheriff's department is way underfunded for the size of the area. Even some volunteer fire departments could use some of that money. And so it would be a community preparedness or protection type of levy.
We can look at it for sure.
Yeah, yeah,
See what St. Regis.
public safety levy,
Slash
or
hospital.
whatever.
Yeah.
Because I'm jealous, back when I was a volunteer fire chief, I was jealous of St. Regis because they got a few $10,000 checks written from their
Mhm.
Sales tax.
Sure.
Has Homeland Security been contacted? I know it sounds ridiculous, but they're into so much. And to say that there's a possibility of losing our hospital, that is the only hospital, say, between the Idaho border and Missoula, I'll bet you they have an interest in that.
Maybe, I think, I
They probably
don't.
have 500 people working in it.
Yeah,
They
I don't.
have very structured grant programs, and I'm not aware of them having a structured grant program that fits this. Obviously, all of our fire departments have benefited from some of their grant programs, and I've written a lot of those kinds of grants.
As does the
Structured
hospital.
program.
The hospital has a grant through DHS that is, helps us
No, they
fund
don't seem to
our
be doing that anymore either.
emergency preparedness programs.
Crap down.
You know,
But again, when you're talking about grants, the way that the government looks at these things is they don't want to fund something that's already going on. They want you to do something new. And so, in order to get grant money, you have to do this new thing and hire some people to do it, and you know, that's, we've done that. We've been there, we've done that here in Mineral County. And I don't plan on going back there, because what ends up happening is, I, as the hospital, pay these people to write grants that then none of the money comes to the hospital, so I just spent all this money to get these grants that somebody else is benefiting from. I can't afford to do that.
Well, and that was one of the things that happened before, were some grants that, they got a chunk of money to do something. There was never a good thought about, okay, once we do this, where's the rest of the money come from to operate it once we get it? It's like, I've got a grant for a fire truck, but I had to both put a match into that grant, first of all, and secondly, now my fire department pays the insurance, pays the maintenance, and operates it. And, you know, every one of those grants has a cost with it.
And if I can get money like the Helmsley grant gave us money to buy the mammography machine, and they're still paying our maintenance on the mammography machine. If I can do those kinds of things, I'm more than happy to do it, because it's things that we need to be doing inside of our facility. But I'm not gonna anymore, we're not gonna be spending money to get, I don't care how much the money is. If it's not gonna benefit the hospital, it's not the hospital's mission, I'm not gonna do it anymore. I can't afford to do that.
Yeah, I think that's a key, and a mistake that was made before is you have to say, okay, there's a grant, does this fit my mission, and can I afford to operate it? And you've got to look at what's your mission, don't go branching out into a whole bunch of other stuff that aren't really your mission, and it's going to cost you a little more in operations, it's going to cost you a little more in management to make those things run. You just can't do that. You've got to focus on your mission. And make sure you're putting your money where it needs to go.
And we're gonna do that.
Yeah.
Okay, well, thank you all for coming.